You walk into the pharmacy thinking insurance is supposed to protect you. Your doctor prescribed the medication. Your plan says you're covered. You hand over your card. The pharmacist types for a second, pauses, looks back at the screen and says, "That'll be $347. Not $34, not $47, $347. And in that moment, you're not thinking about healthcare policy. You're thinking, can I afford to get better? Immediately, your brain starts doing emergency math. Did I hit my deductible? Did insurance reject it? Did the doctor prescribe the expensive version? Is there a coupon? Can I wait until payday? Can I split the pills? Can I just not take it? And the worst part is, nobody at the counter can really explain why the number is the number. The doctor doesn't know. The pharmacist doesn't control it. The insurance company gives you a script that somehow answers the question without answering the question. And behind all of them is a company you probably never chose, never called, and may not even know exists. A pharmacy benefit manager, a PBM, the middleman between your insurance plan, the drug company, and the pharmacy. What if the most important company in your prescription transaction is the one whose name never appears on the bottle? And here's the part that should make you angry. This middleman is not some tiny paperwork vendor hiding in a basement. The FTC reported that the top 3 PBMs processed nearly 80% of about 6.6 billion prescriptions filled by U.S. pharmacies in 2023. The top 6 processed more than 90%. 3 companies, nearly 80% of prescriptions: CVS Caremark, Express Scripts, Optum Rx. And these companies do not just process paperwork. They can influence which drugs your insurance covers, which pharmacies you're allowed to use, how much your pharmacy gets paid, how much your employer or health plan gets billed, and sometimes whether the cheaper drug is easy to get or buried behind a wall of paperwork. So when your medication suddenly costs $347, the question is not just, why is this drug expensive? The question is, who got paid before I got the medicine? My name is Nick, and I spend way too much time thinking about why buying medicine in America can feel like solving a riddle while sick. If you're someone who has ever stood at a pharmacy counter, heard a price that made absolutely no sense, and thought, wait, I have insurance, why am I paying this? Make sure to hit that subscribe button and give this video a thumbs up if this helps you out. Because today we're talking about prescription drug middlemen, the companies that say they lower drug costs, the system that somehow makes cheaper drugs harder to access. The rebates that sound like discounts but can reward higher list prices. The pharmacy contracts that squeeze independent pharmacies. And the reason a drug can cost one price with insurance, another price with a coupon, another price in cash, and another price if you use the pharmacy your plan prefers. And I want you to remember one sentence for the rest of this video. In American prescription pricing, the price you pay is not always the price of the drug. Sometimes it is the price of the maze. Here's the thing. Most people think the prescription drug market has 3 players. The drug company makes the drug. The insurance company helps pay for the drug. The pharmacy hands you the drug? Simple. Wrong. There is a 4th player sitting in the middle of the entire system. The PBM, Pharmacy Benefit Manager. And calling them a middleman almost makes them sound too harmless, like they're just passing paperwork from one desk to another. But PBMs are not just standing in the middle. They are helping decide which doors open, which doors stay locked, and how much it costs you to walk through them. In theory, PBMs exist for a good reason. They negotiate with drug companies. They create formularies, which are the lists of drugs your insurance plan covers. They process prescription claims. They build pharmacy networks. They are supposed to use their size to get better deals. Basically, they are supposed to be the tough negotiator in the room. They are supposed to walk into the room, look at the drug company, and say, "No, millions of patients are behind us. Give us a better price." That is the brochure version. And honestly, the brochure version sounds great. If I described it to you on a whiteboard, you'd probably say, yeah, that makes sense. Bulk negotiation, lower prices, good idea. Here's the problem. Somewhere between we negotiated savings and that'll be $347, the money starts moving through rebates, spreads, fees, pharmacy networks, formularies, prior authorizations, and contract terms that almost nobody outside the system can see. Your receipt shows one number. But behind that one number, there may be a rebate that moves later, a fee that gets charged somewhere else, a pharmacy reimbursement you never see, and a deal between companies that you never agreed to but still live under. That hidden receipt is the one patients almost never get to read. And when the patient cannot see how the money moves, the patient cannot tell who is helping and who is harvesting. The most profitable part of your prescription may not be the pill. It may be the confusion around the pill. Quick question. If a company says it saves you money, but you cannot see the savings when you actually buy the medicine, who are the savings really for? That is the uncomfortable question at the center of PBMs, because PBMs do not just negotiate prices, they shape incentives, and incentives matter more than slogans. If a middleman makes more money when list prices are higher, or when rebates are larger, or when prescriptions move through affiliated pharmacies, then the middleman may not always be rewarded for making your medicine as cheap and simple as possible. They may be rewarded for making the system complicated. And complicated is expensive. Not always directly, not always visibly, but eventually, for you, for your employer, for Medicare, for taxpayers, for the pharmacy down the street, and sometimes for the patient standing at the counter deciding whether to fill the prescription or walk away. Let's make this concrete. Imagine a medication with a list price of $500. That is the sticker price. But the drug company offers the PBM a $200 rebate to get better placement on the formulary. So after the rebate, maybe the real net cost is closer to $300. Now you might think, great, the discount should help the patient. Sometimes it does, but not always in the way people assume. Because if your coinsurance or deductible is based on the list price, you might still feel that high $500 price at the pharmacy counter. Meanwhile, the rebate moves later behind the curtain through contracts between the drug company, the PBM, the insurer, and the employer, so the patient feels the pain immediately. The discount moves invisibly. That is the problem with rebates. A rebate sounds like a discount, but in prescription drugs, the discount does not always happen where the pain happens. You feel the list price today. The rebate moves later, behind the curtain. And once you understand that, the next question becomes obvious. What happens when the system gets rewarded for keeping the sticker price high? Here's what most people don't realize. A discount in healthcare is not the same thing as a discount at the grocery store. At the grocery store, if cereal is normally $6 and it's on sale for $3, you pay $3. You see the discount. You feel the discount. The receipt makes sense. In prescription drug pricing, the discount may happen months later between companies you never interact with. Meanwhile, your out-of-pocket cost may be calculated on a price that nobody actually expects to pay in full. That is why the pharmacy counter feels insane. You are not seeing the real transaction. You are seeing your piece of a much larger transaction. Imagine a grocery store where milk costs $50 at checkout, but the cashier says, "Don't worry, someone else gets a rebate later." You would not call that a discount. You would call that nonsense. But in prescription drugs, that kind of logic can feel normal because it's wrapped in acronyms, insurance language, and paperwork. And this is where it gets really interesting. The drug company can raise the list price. The PBM can demand a bigger rebate. The insurer or employer can say they got a discount, and the patient can still get hit with a huge out-of-pocket cost. Everyone can point at someone else. The drug company says, "We don't control your insurance benefit." The PBM says, "We negotiate savings." The insurer says, "That's your deductible." The pharmacy says, "We just process what the system tells us." And you're standing there holding a bag of medication like you accidentally wandered into a group project where everyone got paid except you. Look, drug pricing is complicated. I'm not going to pretend one villain explains every high prescription cost. Drug manufacturers set list prices. Insurance plans design benefits. Employers choose plan structures. Government programs have rules. Pharmacies have their own economics. But the PBM is the piece most people do not understand. And that is exactly why it deserves attention. Because if you do not know the middleman exists, you cannot understand why the price feels so random. Let's talk about formularies. A formulary is the list of drugs your plan prefers. Tier 1 might be cheap generics. Tier 2 might be preferred brand name drugs. Tier 3 might be non-preferred drugs. And then there are specialty tiers, prior authorizations, step therapy rules, and all the little bureaucratic obstacle courses that make patients feel like they need a law degree to pick up medicine. In theory, formularies are supposed to encourage cost-effective medicine. If two drugs treat the same condition and one is cheaper, the plan might prefer the cheaper one. That makes sense. But here is the dangerous part. A drug's position on the formulary can be influenced by rebates. A higher list price drug with a bigger rebate can sometimes look more attractive to the system than a lower list price drug with a smaller rebate. That is the part that breaks people's brains, because normal people assume cheaper should win. If drug A costs $100 and drug B costs $300, you would think drug A gets preferred. But in a rebate-driven world, the question can become more like, which drug gives the best net deal to the plan? Which drug gives the biggest rebate? Which arrangement benefits the PBM contract? Which product fits the financial machinery? And suddenly, the patient is not just choosing medicine. The patient is living inside a spreadsheet they cannot see. In a normal market, cheaper usually has an advantage. In the prescription drug market, sometimes the drug with the bigger behind-the-scenes rebate gets the better seat at the table. Now you might be thinking, okay, But if rebates lower premiums for everyone, maybe this is worth it. That is the best version of the defense. And to be fair, PBMs argue that rebates and negotiations help lower overall costs for plans and employers. Sometimes negotiated discounts can reduce spending. That is real. But here is the counter question. If the system is saving so much money, why do so many patients still feel crushed at the counter? Why do so many doctors have to fight prior authorization? Why are independent pharmacies saying they are being reimbursed below cost? Why did the FTC say PBMs have enormous power over access and affordability? A system can create savings on paper and still fail the person at the pharmacy counter. That is the distinction. And it matters, because healthcare is not a spreadsheet competition. It is whether people can actually get the medicine their doctor prescribed. Now let's talk about insulin, because insulin is one of the clearest examples of how broken incentives became impossible to ignore. Insulin is not optional. This is not a luxury product. People need it to live. And for years, insulin became a symbol of everything broken in American drug pricing. High list prices, rebate fights, insurance design problems, and patients getting exposed to costs they could not afford. In September 2024, the FTC sued the three largest PBMs, Caremark Rx, Express Scripts, and Optum Rx, along with their affiliated group purchasing organizations, alleging anti-competitive and unfair rebating practices that artificially inflated insulin list prices and shifted costs to vulnerable patients. The FTC's allegation was not just drug prices are high. It was more specific than that. The agency alleged that the rebate system created incentives to favor high list price insulin products, even when lower list price alternatives were available. Think about that for a second. The middleman, whose entire job is supposedly to negotiate lower prices, can be accused by the federal government of participating in a system where higher list prices became part of the business model. That is not a small complaint. That is the whole machine being questioned. If a company is hired to lower prices, but the federal government says its incentive structure helped keep list prices high, what exactly is that company being rewarded for? And this is why the phrase "covered by insurance" can be so misleading. A medication can be covered and still feel unaffordable. A medication can be preferred and still not be the cheapest option for you. A medication can have negotiated savings somewhere in the system and still leave the patient standing at the counter deciding whether to pay rent or fill the prescription. That's the betrayal. The system says, "Good news, you're covered." Your bank account says, "Then why does this feel like a financial emergency?" Now let's talk about spread pricing. Because if rebates are the fog machine, spread pricing is the magic trick under the table. Spread pricing means the PBM charges the health plan or employer one amount for a prescription, reimburses the pharmacy a lower amount, and keeps the difference. So imagine your employer's health plan is billed $100 for a drug. The pharmacy gets reimbursed $72. The spread is $28. Now, maybe there are administrative costs, maybe there are contract terms, but the point is that the middleman can profit from the gap between what the plan pays and what the pharmacy receives, and neither side may fully see the whole picture. Your employer sees one number, the pharmacy sees another number. The PBM knows both. That is power. In what other everyday transaction would we tolerate that? Imagine you hire someone to help you buy a car. They tell you the car costs $30,000. But later you find out they paid the dealer $24,000 and quietly kept the $6,000 difference. And when you ask to see the real numbers, they say, "Sorry, proprietary contract terms." You would not call that efficient. You would call your state attorney general. But in prescription drugs, versions of this structure have been treated as normal business. If your car dealer used pharmacy pricing logic, you might never know the real price of the car, the dealer's cut, or why the cheaper model disappeared from the lot. The FTC's January 2025 report said the big three PBMs generated more than $7.3 billion in revenue above estimated drug acquisition costs on the specialty, generic drugs analyzed from 2017 to 2022. The report also found substantial markups on drugs used to treat serious conditions including cancer, HIV, and pulmonary hypertension. Now, careful language here. Revenue above estimated acquisition cost is not the same thing as pure profit. There are operating costs. There are services, there are complexities, but even with that caveat, the scale is staggering, and the question becomes obvious. If these companies are supposed to make drugs more affordable, why are the markups on some specialty generics so extreme? The FTC highlighted one example, tadalafil, a drug used to treat pulmonary hypertension. According to reporting on the FTC's findings, in 2022 PBMs acquired the drug at an average of about $27 for a 30-day supply, while reimbursement averaged more than $2,100, a markup of over 7,700%, 7,000% on a generic for a serious medical condition. That is the kind of number that sounds fake until a federal agency puts it in a report. And this is where the middleman issue stops being abstract. Because these are not optional products. Nobody is impulse buying pulmonary hypertension medication at checkout. Nobody is saying, you know what would really complete my weekend? A specialty generic prescription. These are drugs people need because their bodies are not functioning properly. And when the price gets inflated through a system they cannot see, they do not experience that as market complexity. They experience it as fear. Now let's talk about vertical integration. That phrase sounds boring enough to be used as a pillow. But it is one of the most important ideas in this entire story. Vertical integration means the same corporate family owns multiple pieces of the healthcare chain. A health insurer, a PBM, a specialty pharmacy, a mail-order pharmacy, a clinic, a data system. So the company managing your prescription benefit might also be connected to the pharmacy it wants you to use. And suddenly the middleman is not just a middleman. The middleman owns one of the exits. The problem may not be that too many companies touch your prescription. The problem may be that the same few corporate families touch it too many times. Let me ask you something. If the same company that insures you also helps decide which drugs you can get, also runs the pharmacy channel you are pushed toward, and also profits from the transaction, who exactly is looking out for you? Maybe the company says it creates efficiency. Maybe sometimes it does, but you would still ask the question. If you hired someone to help you buy a house, and then found out they also owned the house, the mortgage company, the inspection company, and the title company, you would at least pause. You would ask, hold on, whose side are you on? That is the uncomfortable question with PBMs. The scariest part of the prescription drug system may not be that too many companies are involved. It may be that the same few corporate families are involved at too many steps. And that matters because when one corporate structure controls more of the chain, it can steer patients toward its own internal businesses. The FTC's July 2024 report raised concerns about dominant PBMs being part of vertically integrated healthcare conglomerates with links to insurers and pharmacies, and about how that structure can affect access, affordability, and competition. This is why independent pharmacies have been sounding the alarm, because PBMs can set reimbursement rates. They can decide network terms. They can impose contract rules. They can influence where patients are allowed or encouraged to fill prescriptions. And independent pharmacies often say they are getting squeezed from every side. A pharmacy can fill your prescription, lose money doing it, and still get blamed by the patient for the price. That is how broken the incentives are. The patient sees the pharmacy counter. The patient sees the pharmacist. The patient sees the price. So the patient blames the pharmacy. But the pharmacy may be receiving a reimbursement rate set by a PBM, paying fees, dealing with clawbacks or adjustments, and trying to survive in a system where the same corporate giants that set the rules may also own competing pharmacy operations. Imagine being a small grocery store where a giant food middleman tells you what you'll get paid for milk, charges the customer through a secret formula, owns the supermarket down the street, and then acts surprised when your store closes. That is why pharmacy access is not just a business story. It is a healthcare story. In many communities, especially rural or underserved areas, the local pharmacy is not just a place to pick up pills. It is where people ask about drug interactions. It is where older patients get help understanding dosage. It is where someone notices if a prescription looks wrong. It is sometimes the most accessible healthcare professional in the neighborhood. When that pharmacy closes, the spreadsheet may say market consolidation. The patient says, now I have to drive 40 minutes to get my medicine. Those are not the same sentence. A pharmacy closure does not show up on your receipt. But you feel it the next time your medication is delayed, transferred, mailed late, or stuck in a call center. Now let's talk about the psychology. Because the reason this system has survived for so long is not just money. It is invisibility. Think about the last prescription you picked up. Can you name the PBM that processed it? Can you name one PBM at all? Before this video, could you have explained what the letters PBM stand for? If the answer is no, you're not uninformed. You are exactly where the system expects you to be. When you pick up a prescription, you see the pharmacy's name, you see the drug manufacturer's name, you see your insurance company's logo on your card. But the PBM? Usually invisible. And invisibility is powerful, because when the price is high, you blame the names you can see. The drug company, the pharmacy, the insurance company, maybe Congress, maybe yourself. You think, I should have picked a better plan. I should have used a coupon. I should have known. That is the psychological trick. The system is huge, but the patient experiences it as a personal failure. And money tied to medicine is especially emotional. It's one thing to overpay for a vacation. That hurts, but you chose the hotel. You chose the flight. You can say, I'll do better next time. Medication is different. When you're at the pharmacy, you are not shopping in the normal sense. You are sick, or someone you love is sick. You may be tired. You may be scared. You may be standing there with a kid in the car. You do not want to negotiate. You do not want to comparison shop. You want the thing your doctor prescribes so your body can function. That changes everything, because a normal consumer can walk away from a bad deal. You can look at a $900 sweater and say, absolutely not. But if your kid needs an inhaler, or your parent needs insulin, or you need an antidepressant that actually works for you, walking away is not really a choice. How much comparison shopping are you really going to do when the thing you're buying is the thing that lets you breathe, sleep, focus, or stay alive? That psychological pressure gives the system enormous power, and the system knows it. You are not sitting there with a spreadsheet. You are thinking, can I afford to feel better? That is why this topic matters, because the confusion is not just an accident around the edges. The confusion is part of how the money moves. And once you understand that, one question becomes unavoidable. Who profits when you are too overwhelmed to ask for a different price? Now let's talk about the weirdest experience in American pharmacy pricing, the cash price. A lot of patients have had some version of this happen. The pharmacist says, with insurance, it's $80. Then you check a coupon app or discount card and it's $22. And suddenly the American healthcare system looks like a haunted vending machine. How can insurance be more expensive than not using insurance? Well, because your insurance price is not just the price. It is the output of your plan. Design, deductible, formulary tier, pharmacy contract, PBM arrangement, and sometimes whether that pharmacy is preferred. The cash price or discount card price runs through a different channel. Sometimes that channel is cheaper, sometimes it is not. But the fact that patients have to comparison shop at the pharmacy counter for medicine their doctor prescribed is absurd. Imagine if a restaurant worked this way. The waiter says, your burger is $48 with your dining insurance. Then you open an app, and it says, actually, if you pretend you don't have dining insurance, the burger is $13. Then the waiter says, do you want this to count toward your deductible? And you say, I don't even know what a burger deductible is. That is prescription pricing, except less funny because people need the burger to not die. Here's the practical point. Sometimes using a discount card or paying cash can be cheaper than using insurance, but there is a trade-off. If you pay outside insurance, it may not count toward your deductible or out-of-pocket maximum. So for a one-time generic, cash might be smarter. For a medication you take every month, especially if you expect to hit your deductible, the calculation changes. This is why you ask. At the pharmacy, say, what is the price with insurance and what is the cash price? Then ask, is there a lower-cost generic or therapeutic alternative my doctor can approve? And, does this count toward my deductible if I use insurance? You are not being difficult. You are asking basic questions in a system that decided basic answers should require detective work. If your insurance price is higher than the cash price, that does not mean you are bad at healthcare. It means the pricing system is bad at being sane. Now let's talk about your doctor. Because the moment a prescription is written is often the moment you have the most leverage. Most doctors are focused on the medical question. Does this work? Is it safe? Is this the right treatment? That is what you want them focused on. But many doctors do not know your exact insurance price. They may not know your PBM's formulary rules. They may not know whether your plan prefers one drug over another because of a rebate arrangement, a tier change, or a prior authorization rule. So you have to bring cost into the room. And I know that feels uncomfortable. A lot of people feel embarrassed saying cost is a concern. Please stop being embarrassed. Cost is part of healthcare. If a medication is technically effective but you cannot afford to take it, then the treatment plan failed in the real world. So ask, is there a generic version that would work for my situation? Is this the cheapest effective option on my formulary? If insurance rejects this, what is plan B? Is there a lower cost alternative in the same class? Could a different dosage or formulation change the price? Do not change your medication without medical advice. Do not split pills or skip doses because a YouTube video told you to, but ask, because silence is expensive. And in healthcare, silence can be dangerous. Asking for a cheaper medication is not being cheap. It is refusing to let a billing system make medical choices for you. Now let's talk about your employer. If you get insurance through work, your employer may not fully understand what is happening either. That sounds ridiculous, but it is real. Large employers hire consultants, insurers, PBMs, brokers, and administrators. The employer may think the PBM is saving money because the contract shows discounts and rebates. But if the contract is opaque, the employer may not know whether the lowest net cost drugs are being preferred, whether spread pricing is happening, whether rebates are being passed through or whether employees are being pushed into higher out-of-pocket costs. Your HR department may be trying, but they are often not drug pricing forensic accountants. And that is another reason complexity survives. The patient cannot see it. The employer may not fully see it. The pharmacy is bound by contracts. The doctor is buried in prior authorization. And the middleman knows the map. If you control the map, you control the journey. So if you have a recurring drug cost problem through an employer plan, tell HR or benefits specifically, not emotionally, specifically. I was prescribed this medication. The plan required this process. It delayed access by this many days. The out-of-pocket cost was this much. Is there a plan option or exception process? Or, I've been learning more about pharmacy benefit managers. Does our plan use spread pricing or a transparent pass-through model? Are rebates fully passed through to the plan? Has our pharmacy spend ever been independently audited? You're not accusing, you're asking. And even if HR does not know the answer, that question can get forwarded to the broker, the benefits consultant, or the plan administrator. That matters, because employers are often the ones signing the contracts. And if employers do not ask hard questions, the contract keeps doing what the contract does. Your employer may be overpaying for your prescriptions, your pharmacy may be underpaid, and you may still be charged too much, all inside the same transaction. Now let's talk about open enrollment. Most people choose health insurance by looking at three things: premium, deductible, doctor network. That's already annoying enough, but if you take recurring medication, you have to check the formulary. I know. Very fun weekend activity. Nothing says adult joy like downloading a 90-page PDF to see whether your medication is Tier 2 or Tier 4. But this can save you thousands. Because a plan with a lower premium can be more expensive if your medication is treated badly. Let's say Plan A is $200 a month. Plan B is $300 a month. Plan A looks $1,200 cheaper per year. But your medication under Plan A has 30% coinsurance after deductible, and under Plan B, it has a fixed $40 copay. If that medication has a negotiated price of $900 a month, Plan A could bury you. Plan B might be the real cheaper plan. That is the prescription drug version of don't only look at the monthly payment. The premium is not the price. The total yearly cost is the price. And yes, this is exhausting. You are basically predicting your future illness through a PDF. Very normal country, but ignoring it can cost thousands. A cheap insurance premium can become very expensive if your medication is trapped on the wrong tier. Now you might be thinking, Nick, I have good insurance. Does this matter to me? Yes, because good insurance can become mediocre insurance next year. Formularies change. Employers switch plans. PBMs change preferred drugs. A medication that is easy today can become annoying tomorrow. You might be thinking, I don't take prescriptions. Great, I hope that continues. But someone in your family probably does, or will. One serious diagnosis can turn this from trivia into urgent financial knowledge. You might be thinking, isn't this too complicated for me to do anything about? No. You do not need to understand every rebate contract. You need to understand enough to ask better questions. You cannot personally fix the PBM industry at the pharmacy counter, but you can stop being the easiest person in the system to confuse. You do not have to beat the whole system. You just have to stop letting the system give you one price and convince you it is the only price, because most financial wins come from small moments where you stop autopiloting. This is one of those moments. So here's the practical checklist. Before you pay for a prescription, especially if the price surprises you, ask, what is the insurance price? What is the cash price? Are there discount card prices available? Is there a cheaper generic or therapeutic alternative? Does this count toward my deductible? If the medication is new, ask your doctor, but is there a cheaper option that works for my situation? If this gets rejected, what is Plan B? If this requires prior authorization, can your office help submit that? If the prescription is expensive or delayed, document everything. Dates, calls, names, reference numbers, messages to your doctor. If the delay affects your care, ask your doctor's office to mark it urgent or medically necessary. Paper trails matter. Boring, yes, but paperwork is how you fight a paperwork monster. If you take expensive medication, review your plan during open enrollment like your health depends on it, because it might. Do not just compare premiums, compare formulary coverage. Deductibles, coinsurance, specialty tiers, preferred pharmacies, mail order requirements, out-of-pocket maximums. And if your plan forces you into a specialty or mail order pharmacy and it creates delays, say something. Tell your doctor, tell the plan, tell HR if it is employer coverage. The system depends on people treating bad access like a private inconvenience instead of a documented failure. The next time you hear a prescription price, don't ask only, "Can I afford this?" Ask, "Is this the only price?" Now let's zoom out. PBMs are not cartoon villains. This is not one guy in a black cape counting pills. The villain is a structure, a middleman structure that claims to negotiate savings while operating through opaque contracts. A rebate structure where high list prices can still matter. A spread pricing structure where the gap between what the plan pays and what the pharmacy receives can become income. A vertically integrated structure where the company managing the benefit may also own the pharmacy channel, and a patient experience where the person who needs medicine is often the last to understand the price. That is the real scandal, not that middlemen exist. Middlemen can be useful. The scandal is middlemen with enormous power, limited transparency, and incentives the patient cannot audit. If PBMs truly save patients money, then the system should be able to show it clearly. At the counter, on the bill, in the formulary, in the contract, in the patient's actual out-of-pocket cost, because savings that only exist behind a curtain are very convenient for the people behind the curtain. Now you might be thinking, this is bigger than me. Yes, it is. This is a policy problem, a market concentration problem, a healthcare transparency problem, a lobbying problem, a contract problem. But big systems are still made of small decisions. You can ask the cash price. You can compare pharmacies. You can challenge a prior authorization delay. You can use open enrollment more carefully. You can tell your employer benefits team when the plan fails. You can support transparency rules. You can stop assuming the pharmacy counter price is some law of nature, because it is not. It is the output of a machine. And machines can be questioned. You may not be able to redesign the machine today, but you can stop treating the machine's output like it came from the sky. The bottom line is this. Prescription drug middlemen survive in the shadows because most people never learn their names. Patients blame the pharmacy. Pharmacies blame the PBM. PBMs blame drug companies. Drug companies blame rebates. Insurers blame plan design. Employers blame rising healthcare costs. And the patient just wants the medicine. That confusion is not a side effect. It is part of the system's power. So the next time a prescription costs more than expected, do not just ask, "Why is this so expensive?" Ask better questions. Is this covered? Is there a generic? Is there a preferred alternative? Is this price with insurance or cash? Does this count toward my deductible? Is this pharmacy preferred? Does my plan require mail order? Does this need prior authorization? Can my doctor request an exception? And most importantly, who benefits from me paying this price? Because somewhere between the doctor's prescription and the pharmacy counter, your medication entered a financial maze. And the middlemen know that maze very well. You do not have to become an expert overnight, but you do have to stop treating confusion as normal. Because when confusion becomes normal, overpaying becomes automatic. Ask the annoying questions. Read the formulary. Compare the real price. Push back when the process delays care. And remember, in American healthcare, the most expensive person in the room is often the one you never meet. Because the system does not need you to understand PBMs. It just needs you to keep blaming yourself when the price makes no sense. Terms apply.